Okay, I'm going to go ahead and start. I'm Lee Shapiro. I'm from upstate New York, although it can sometimes get this hot and humid there as well. And I'm going to talk about the vascular disease in scleroderma. Now, a triad is often drawn in terms of what matters in scleroderma, consisting of fibrosis, vascular disease, and autoimmune phenomena. And the world of researchers is broken down in large part by those who focus on one or another of those aspects. I've always been drawn to the vascular disease because I think it's more basic than the fibrosis. And more universal. So it comes first. Almost always, if someone's going to have Raynaud's phenomenon, they have it before anything else has happened to them. It affects just about everyone with scleroderma. Whether or not they have Raynaud's, they have some other manifestation of vascular disease. And it's present in every affected organ that is involved with scleroderma. That is, you see vascular changes. So a lot of people, a lot of physicians too, if you're diagnosed with scleroderma, they immediately think about fibrosis. And of course there is fibrosis, but it's not in everyone. There is this entity called systemic sclerosis sine scleroderma, where individuals can have Raynaud's and esophageal disease and interstitial lung disease. But look as you might, you don't find fibrosis in the skin, and they never do get skin thickening. So that's why I say the skin changes, the fibrosis, are not as universal as the vascular changes. And the vascular changes have a remarkable uniformity no matter what part of the body is involved. So this is a slide that was actually developed by Dr. Rodnan 30 or more years ago, showing blood vessel changes in a finger here. This is a digital artery, and the cut across the finger. And really, this blue area is what's called the intima, or the internal lining of the blood vessel, and it's almost completely obliterated by what's called intimal fibrosis. This is the lung of someone with pulmonary hypertension. And again, you should be able to see a lumen that's just about this big, and you really can hardly see any at all. And this is the kidney with an intrarenal artery, or a smaller vessel than that, again with almost complete obliteration. So the changes are similar no matter what organ is involved. And actually, when you look at those vessels, it's amazing how separate there sometimes is between the pathologic findings and the clinical presentation. That you can have that much narrowing and few symptoms. So Raynaud's phenomenon was described a long time ago. It was not immediately associated with scleroderma. I can't quite tell you when that connection was made, but we know it's the most common symptom of scleroderma. I'm going to talk mostly about those symptoms that you might not think are vascular, but which I think are vascular, and I'm going to try to convince you of that, try to show the evidence for that, or at least make some hypotheses, and end up talking about new treatment approaches and an ultra-rare disease that I encountered recently, which I think may have some lessons for scleroderma, and also instilled in me a belief that fate can be altered and that miracles still do happen. So we'll get to that. Renal crisis was developed in the year I was born, and somehow I matched these dates with scleroderma with major events in my life in terms of just feeling some kind of connection. And then pulmonary hypertension was linked the year I went to Pittsburgh, and it was in fact done at the University of Pittsburgh. A cardiologist there working with Dr. Rodnan described this association of pulmonary hypertension with limited scleroderma. So everything that we kind of take for granted now, there was a time when these connections were not known. And knowing them makes a huge difference. So the fact that renal crisis was described, well, that was a starting point. But what occurred subsequently was that largely through Dr. Steen, the risk factors for scleroderma renal crisis were identified. Through the combined work of Dr. Rodnan and others, treatments for scleroderma renal crisis, the ACE inhibitors were developed. We had an effective treatment based on understanding of the pathology. Disturbingly, there's still a lot of people who get renal crisis without knowing that they were at risk of it. So we have still a terrible problem of failure of education too often. That's really more an issue for physicians than for the individuals with scleroderma. But we have effective drugs, and it's a matter of getting them there in time. And same thing with pulmonary hypertension. Through the work, again, of Dr. Steen largely, we know the risk factors. We know the stronger association with limited scleroderma and with an isolated decline in the diffusing capacity over time. And now, in 1977, there were no treatments for it. Now there are 13 treatments, as mentioned before. There are probably going to be more all the time that are less onerous, and we'll probably get to a point when we really know the risk factors better, that treating pre-pulmonary hypertension will be approved. That is, using these drugs before someone is short of breath and symptomatic. So I'm going to review both the well-known and the lesser-known vascular aspects of scleroderma, talk a bit about the mechanisms of vascular damage, and discuss some possible therapeutic approaches. And I have no disclaimer slide, so you'll just have to take it verbally. So the skin changes, well, notably, I'm not going to talk about fibrosis. I know fibrosis is there, and a lot of other people are working on fibrosis, and I'm not going to address it. I'm going to acknowledge it and also talk a little bit about how it might be connected to vascular disease. So the common findings are the Raynaud phenomenon, which we will talk a lot more about, the nail bed capillary changes, and the telangiectasia. And Raynaud phenomenon is interesting because it's a short-term event, but in individuals who really have long-term vascular changes. This slide says a lot. First of all, the thumbs are not involved, and we're not exactly sure why that is, but the thumbs, if I asked all of you, probably most of you would not have involvement of the thumbs. They are involved only about 12% of the time. And the digits may be involved, same trigger, it involves them differently. Some just the tip, some not at all, some half the finger, some just the distal phalanx. But the important point I want to make is that this is an extreme event, but in these individuals with, who have Raynaud's in the setting of scleroderma, after the episode has resolved, the finger is not a normal finger. That most individuals with scleroderma and a prolonged history of Raynaud's, their fingertips are always cold. Their fingertips are always hypoxic. And so if you bought seeds that show these different climate zones in terms of temperature and lowest temperature, those charts in terms of what will grow and what won't grow, the fingertips of an individual with scleroderma with Raynaud's have their own microclimate. And it's a climate that's colder than the rest of the body, and it is hypoxic related to the rest of the body. It's got a low oxygen tension if you measured, again, even between episodes. During the episode, it's obvious and it's extreme, but I'm talking about changes that are there 24 hours a day, 7 days a week, 365 days a year. Even here in New Orleans, where I'm sweating, those of you who have cold fingers probably still have cold fingers. Maybe some don't. And if we don't do this study very often, except perhaps if we're looking for individuals who might benefit from surgical interventions, individuals who have had non-healing digital ulcers, and there's the question of whether large vessels are involved. And large vessels are involved in perhaps 10% of individuals with scleroderma. And in a lot of individuals with scleroderma, if you check pulses, the ulnar artery pulse will not be present. But in this individual, obviously, there's a very healthy ulnar artery. Actually, it looks healthier than the radial artery. And there's this arch. And then here the thumb is involved, surprisingly. But again, these fingers differ in terms of just where the cutoffs occur. And that's in the midst of an episode of Raynaud's. If you gave a calcium channel blocker in the midst of the procedure, you'd see much better perfusion, but it would probably never get normal in the vast majority of individuals with scleroderma. So Raynaud's is a sign of those individuals in the setting of scleroderma who have a climate at their digits that is not normal. And we'll talk about the consequences of that. So it only took one doctor. It was a doctor in South Carolina who was working with Dr. Silver, Dr. Marique, who happened to notice something that was always there. So it's interesting, this meeting is unmasking the cure. She didn't really come up with a drug discovery, but she just made a notice of a physical finding that was always there and was ignored, and which turns out to be invaluable, especially in early diagnosis and possibly in tracking people over time in regards to the severity of the vascular disease. And that are these nail bed capillary changes. And this slide isn't so great, but we're going to come to better ones. That sometimes with the naked eye, you can see these dilated capillary loops. They don't happen in too many other conditions. They don't happen in individuals with Raynaud's who don't have scleroderma. They can happen in dermatomyositis, which is another disease where there's a big vascular component. But if someone comes in with a history of new onset of Raynaud's, and you see these dilated nail bed capillaries, this is as powerful as any blood test in terms of saying they have scleroderma or possibly dermatomyositis. They don't have what's called primary Raynaud's. So this is what they would look like with some level of magnification. Those are normal, and there might be one little one there that's a little more squiggly, but over time, the density of the vessels diminishes, and you get these grotesque or bizarre, giant, complicated loops occurring. And it can culminate, again, in really striking paucity of blood vessels, of small blood vessels. And that's important visually. It can also show the evolution over time. But I think also it tells us something about that individual's finger. Again, as far as what the temperature is over time, what the oxygen level is over time. And this shows it a little more dramatically. Again, this is normal. But you get this progression of bigger loops, but fewer loops. And so telangiectasiae, these red dots that could develop anywhere, if you take a hand lens, they look very similar to this. Really, they are a tangled web of blood vessels, Medusa's hairpiece. And I don't think that's fair to Medusa. But what the body is trying to do is grow new blood vessels because they're being lost at different pace in individuals with scleroderma, probably continuously over time. And individuals with scleroderma have high levels of something called vascular endothelial growth factor. So there are these efforts to grow blood vessels. Those blood vessels enlarge, some of them disappear, but the ones that remain enlarge, they have this stimulus to growth. But there's a great problem forming new blood vessels. So as a consequence, I just want to bring up some other manifestations regarding the skin that are maybe not as immediately apparent or considered. And that is many people with scleroderma over time will have thinning of their lips. Yes. Yes. So, or they may even have cold lips. And loss of earlobes doesn't happen to everyone. And we'll talk more about this process, but the body has the ability to sense what the oxygen level is in a tissue. And not just to sense it, but to respond to it. And the body has a process called apoptosis, or programmed cell death. So if there's not enough blood flowing here, you don't get a whole crop of sores on your lips because it doesn't happen all of a sudden. It's not like a crash landing. It's more like the disassembly of a building in a very orderly fashion. So at 9/11, there were, of course, buildings that crumbled, but there were other buildings that were in poor shape and needed to be disassembled, and they didn't crash. They were taken down piece by piece. And so I believe what happens to the lips is a similar process, that there are sensors there. The lips are usually dramatically well perfused. If you had trauma to a lip, you would bleed, bleed, bleed. But then in individuals with scleroderma, there's a dramatic decrease in the small blood vessels. And Dr. Freck at the University of Utah, who is another individual who is focusing on the microvascular disease of scleroderma, is looking at the blood vessel density under the tongue and has found that it is reduced, in some individuals greatly reduced. And these studies are very early. But again, I believe that just as what we saw at the nail fold, that these kind of changes happen in many, many places in individuals with scleroderma. And in those who lose their earlobes over time, or other facial changes like thinning of the nose, that once we have better ways of looking at blood vessels in those areas, we'll see that there is this progressive loss of blood vessels. And the body responds by recognizing the supply is not adequate to maintain the normal tissue. And again, instead of having some catastrophic event like a gangrenous change or ulcerations in these areas, that the body just slowly thins the tissue. So calcinosis we're going to talk about too a little bit. But I'll go ahead and talk about it now. I'm not good at saving my thunder. And so calcinosis, people might not think of as also a manifestation of microvascular disease. But if you have scleroderma for a long period of time, those fingertips are the most common spot to get calcinosis. And I believe, and I'll show you a slide that shows this pretty dramatically, that the calcinosis is probably related in many people to loss of bone at the fingertip. That a common feature in individuals with scleroderma of long duration is not just thinning of the lips, loss of earlobes, but loss of the pulp and of the length of the distal phalanx, the distal most portion of the digits. And the more severe your Raynaud, the colder your fingers, the longer you've had scleroderma, the more likely those changes will occur. And if you take an x-ray of the hands of such an individual, you will see the bones in the distalmost portion of the finger look thin. There's localized osteoporosis. This doesn't show up on a bone density study, which just looks at the hip and the spine and the forearm. But we're hoping to study bone density in the digits with collaborators at Columbia. They have a machine that can do quantification of the bone density in the digits and compare the proximal phalanx, the mid phalanx, and the distal phalanx of the finger. And I think what we'll see is that there's a linear drop-off of bone density as you go out in the finger and as the oxygen supply gets lower and lower and the finger gets colder. And then there's something called acro-osteolysis, that if the bone gets disassembled enough, it will disappear. And if you look, and I'll show you an x-ray of an individual with scleroderma of long duration, you will often see on an x-ray that a good portion, sometimes even all of the bone at the distal phalanx has disappeared. And then often right next to that lost bone, there's a calcium deposit. And the flow there is so slow that I believe, and we have yet to prove it, that those calcium deposits are really collections released from that bone that got disassembled. That the body really isn't able, just like it isn't able to nourish the bone, it isn't able to transport the calcium very far away.
Excuse me, would that affect the feet also?
It could certainly affect the feet as well. Now, we have a lot further work in regard to explaining that, because you can get calcinosis on your forearms or your knees or elbows or buttocks. Doesn't mean it's not related to hypoxia, but no one's really looked as carefully in those other areas. So ankle ulcers can also be another feature of individuals who have this severe generalized, again, there's a gradation of severity, and some people have, everyone has vascular disease, as I mentioned, but some don't have it so severely. In those who have it most severely, if there's trauma, if there is extrusion of a little piece of calcium, if there's anything that causes an ulcer, it persists because there is so little blood flow and so little ability to grow new blood vessels to result in rapid healing. And when there is healing, and I don't have a slide of this, but the wound healing is not typical in scleroderma. And if you look carefully at a healed ankle ulcer, you'll see those giant capillary loops that you see at the base of the fingernail. You won't see a dense collection of small blood vessels as you would in a normal wound. It's a very avascular scar. So those are the thin lips. And sometimes they're thinner. Same individual, probably if we had her flip down the lip, we would see telangiectasia. Again, because if you have several of these features of the more severe vasculopathy of scleroderma, and again, we're not talking classic peripheral vascular disease, we're talking about very small blood vessels. The more features you have, the more features, if you look further, you'll find. And so this is a very important slide in terms of talking about the bone in the digits in people with scleroderma of long duration. Not everyone does this. Calcinosis happens to about 25 to 30% of individuals with scleroderma, but about 70% of individuals with pulmonary hypertension. And those individuals with pulmonary hypertension, well, first, pulmonary hypertension is a vascular process. It's the result of loss of lots of small blood vessels in the lung. And I believe this is also a vascular process. So it's reasonable that these two processes should be associated. But this X-ray shows a lot of things. I can read more into it than is probably there. First, there's a variation, just as with that picture of individuals with Raynaud's, there's a variation from digit to digit as to the extent of involvement. Don't know how to explain that, but we know that the angiographic changes, again, will vary. So this is close to normal in length, and there's a tuft at the distal portion of this distal phalanx. So the bone has this appearance of broadening at the top. So these are decidedly abnormal. They're short, and they've lost this big blossoming at the top, and they're also thin. So if you compare the bone density down here to up here, this is not a bone density study, but I think you could say this bone looks very washed out. And in the proximal phalanx, it looks much denser. And in the mid phalanx, especially as you go further out, I might be able to convince you that there's thinning there, and there's certainly thinning here. There's none of this cortex, which you can just make out here, but normally you can see much more clearly even in the distal phalanx. So these bones are getting disassembled. They're disappearing. And here here you're losing bone, and right next to it, you're depositing calcium. So I am a strong believer that those two events are connected, and we're trying to come up with means of proving that. And then I believe that the answer to this would be increasing the blood flow to the fingers, at least to the extent that you stop losing bone.
Dr. Shapiro, are those fingers where the end bone is triangular? Is that the normal shape of the bone in those digits?
No. So all the fingers should look the same. They should all look more or less like this one. So it's shortened. It's shortened, and it's in the process of getting still shorter.
Thank you.
So that's the skin. We're going to come back to it a little bit. So vascular manifestations also affect the gastrointestinal tract, and of course some of them are very well recognized as vascular events. They couldn't be anything else. They stare you in the face as vascular events. But I believe that vascular disease is really the basis of all of the GI disease in scleroderma. That's kind of bold, but I'll work my way up to that. So we know there are vascular changes in the stomach. The most common cause of bleeding in individuals with scleroderma is this watermelon stomach, which also called gastric antrovascular ectasia, ectasia meaning enlargement of these blood vessels. And it must have been a very hungry gastroenterologist who looked in the stomach and made this term. And there's a big move now in medicine to take the names of doctors who describe things away from that disease or that process and to describe it in some other way. But I'd rather have a doctor's name than a food name. So it's also known, so that's the most dramatic, that you can get these red dots, telangiectasia, if you have them in your fingers, if you have them on your face. If we flip the upper or lower lip, if we look at the roof of your mouth, if you have an endoscopy or colonoscopy, it's certainly not unusual to find these same kind of vascular changes. But this is the part that we have yet to prove. And again, people talk about scleroderma as fibrosis. And if you look at the bowel, though, there is some fibrosis, or what's called patchy fibrosis. But the more common process is that there is thinning. So if you do a CT scan of the chest in someone who's had scleroderma for a long time, you'll often see that there's a dilated esophagus with a thin wall. And so I think the process is, what the very beginning of the GI tract at the lips is telling us is true throughout the GI tract, that there is this process of gradual thinning. And if you get a thinner wall and everything in the GI tract is really muscle, as well as absorptive surface, as well as lymphatic tissue, if it gets thinner and thinner, it gets weaker. And if that happens in the esophagus, it enables reflux and causes motility disturbances. If it happens in the stomach, it causes gastroparesis. If it happens in the small bowel, it causes small bowel bacterial overgrowth and bloating. If it happens in the colon, it can cause constipation. And if it happens in the rectum, it can also cause constipation, and it can cause some loss of continence. So I believe that this provides, I had to figure out, how do I tell people who come in with Raynaud's phenomenon and reflux who have new onset of scleroderma, how are these two symptoms connected? And it took many years of thinking to come up with an answer that would tie the two together. So I really believe they are both manifestations of the same process, which is progressive loss of small blood vessels. So at the fingers, there's this coldness and gradual shortening. And in the GI tract, there's this loss of thickness and weakening of the esophagus, most commonly, and we still don't know exactly why that is, but one theory is that the esophagus is the only part of the GI tract that is exposed to cold. So when you drink cold vessels, there may be esophageal Raynaud's phenomenon and further tightening of those blood vessels.
Is the vascular on the hands and all that, are they with people that aren't being treated with something like Cialis or any of the other?
Okay, so that's a very good question, which I don't believe anyone's really followed that over time in terms of whether there's, people really haven't studied very much the rate of bone loss over time. But Cialis and all the other treatments for Raynaud's and all the treatments for pulmonary hypertension, with possibly one exception, work by dilating the blood vessels that are there. They don't result in the appearance of new blood vessels, so there's a limit. You're going to hit a wall in terms of how good it can get. So we know Raynaud's in individuals with scleroderma is more resistant to treatment than Raynaud's in individuals who don't have scleroderma. In fact, they don't really need treatment, most of these other individuals, because between episodes, they have normal flow. They just get spasm, and if you reverse the spasm, they have normal flow. In individuals with scleroderma, even with a Cialis. That might take care of the painful attacks. It might help enough to prevent digital ulcers from appearing. But the fingertips are usually still, not always, but often still cold.
I've been doing it for like 6 years, and I've noticed a drastic reduction of cold.
Okay. Well, there are some people who are lucky like you, and we hope.
I'm going to hit a wall.
I won't say that you'll hit a wall. I think you're a responder, and some people are much more responders than others, and so you're also lucky, and you're lucky to have access to the drug, because that's another issue that, as these agents come out, that's an off-label use of Cialis that we can't get the drug.
I had an excellent doctor wrote a really scary letter.
Okay, so so there's watermelon stomach, and again, I just believe he had to be really hungry. And I just, so they're, just as the fingers are involved differently, different parts of the GI tract can be involved differently. And so this is a small bowel, but so is this. And this is, you can see, massively dilated. And I believe the reason it is that the wall is thin and the wall is weak, and that is what makes that possible to happen. Now, what about fibrosis? There can be patchy fibrosis. So we need more people involved in translational research to really help some of these things. But I kind of think of fibrosis as what would happen in your house if you had a budget for maintenance or renovation and you ran out. And so instead of having the stonework that you wanted or the brickwork that you wanted, the contractor says, well, gee, the only thing we can do is just put up some drywall or some, put up some, just patches that aren't going to be brick. They're not going to be stone. They're not going to be beautiful. They're not what you wanted. But they will keep the wind from coming through your wall. So the fibrosis, and I don't know how generally this is true in scleroderma, but we'll talk a little bit more about that. The fibrosis is a way of patching things up without requiring as much oxygen, as much blood flow, that you have tissue that's relatively inert, and it may be the body's means of economizing when it doesn't have sufficient blood flow to perfuse muscle. Yes?
Can the fibrosis in the intestine be that cause to abdominal pain?
Well, certainly if you have fibrosis there, it's not going to function like muscle. And the contractures in the GI tract tend to be very rhythmic. And so if it hits a band of fibrosis, it's going to knock the rhythm off. And yes? So, yeah. Well, that certainly, the body doesn't want that to happen. That would be catastrophic. And so I think that the body has developed means of avoiding that outcome. And that's why I say I think one of those is it has the patchy fibrosis, so events like that don't occur. And same thing with the esophagus. Again, this is, the upper esophagus is kind of normal, but this is not a CT scan chest X-ray with the barium in the esophagus, and it shouldn't be anywhere near that wide. So if it was an esophagus of normal strength, it just wouldn't do that. It couldn't do that. And it does that because it's weak and it's thin.
So, Dr. Shapiro, some of the esophaguses get really little and some go like that?
They don't get little.
Or they get narrow?
Well, if they get narrow, it's because of reflux that may not have been adequately addressed and cause scarring on the inside. So you can get scarring on the inside, but the reason that you're getting the reflux is because there is weakness in the sphincter that's allowing the reflux to occur. Okay, so the kidney, again, kidney's interesting because those blood vessel changes that I showed you on the first slide, they are there in many, many, many individuals who don't get renal crisis. So the vascular changes that are found in someone with renal crisis didn't just occur, although the renal crisis can happen in a day or a week. So something may be sort of the equivalent of Raynaud's in the digit, again, where there's poor blood flow all the time, but something can make it much worse. And in someone with scleroderma, that can be dehydration, it can be heart failure, it can be development of an effusion around the heart that decreases the pumping ability of the heart. It can be high-dose steroids that somehow diminish blood flow in the kidney. So renal crisis is an event on top of existing architecture, just like Renos Phenomenon is an event on top of blood flow in the fingers that is not normal. And then erectile dysfunction, just as with Renos Phenomenon, there are responders to Cialis and there are non-responders. And it's because the blood vessels may not be there to dilate with the medication. This is the, again, small intrarenal vessel, virtually no lumen. And as I mentioned, you see that if you do biopsy in someone with renal crisis. You don't usually need to do a biopsy because it's generally in the setting pretty obvious what the problem is and what the treatment is. But sometimes there could be other forms of kidney disease in scleroderma. But you'll see changes that are almost identical to those in the finger. And if you do an angiogram, which isn't done, this is a post-mortem exam, because if you do an angiogram in someone who has kidney failure, you'll make the kidney failure worse. But it looks like a tree that's been pruned very severely. There are a lot fewer blood vessels in the kidney in someone with scleroderma, even if they don't have renal crisis, at least in individuals with diffuse scleroderma. Okay, so pulmonary hypertension is well recognized as a vascular manifestation, really a small vessel vascular manifestation. You don't have to have any fibrosis in the lung to get pulmonary hypertension. You might have some, but you don't need to have any. And right now, we screen for it, but these abnormal blood vessels have to have been there for a very long time. And so we know there's a state also what's called pre-pulmonary hypertension. So these are people at risk of it who don't have it. And some may never get it. And again, just like some people respond to vasodilators and others don't, disease advances at different rates in different people. And so we try not to be alarmist, not to treat everyone. But it would be nice in those people to be better able to predict who's going to get shortness of breath and to intervene with these drugs now that we have them much sooner. So again, the blood vessel changes are there. When you have a declining diffusing capacity, an isolated decline in diffusing capacity, there's less blood going through your lungs. There's loss of small blood vessels in the lung, but not to such a degree as to increase pulmonary vascular resistance and cause pulmonary hypertension. Okay, so there is a myopathy of scleroderma. Scleroderma can overlap with polymyositis. That's an inflammatory muscle disease. But there are other individuals who develop a non-inflammatory myopathy, that they can get proximal weakness. Their muscle enzymes may not be elevated as they would be when there's muscle injury or inflammation, but they may have difficulty getting off the toilet, getting off a chair, climbing stairs, and it's not due to joint pain, but it's due to a weakness in their thighs or weakness at their upper arms. And if you do an EMG, electromyogram, you don't see muscle inflammation. If you do a muscle biopsy, you don't see muscle inflammation. But I believe, because I've seen a bunch of these people who also had pulmonary hypertension and Raynaud's and ankle ulcers and calcinosis, that this is another feature in that constellation of the people with the most severe microvascular disease, that if you looked in the muscle for blood vessels, you'd find that there's a diminished number, and you do see what is seen on the biopsies of these individuals is muscle atrophy. So we talked about osteoporosis. So in the digit of someone where it's always cold, I wondered, how does the body know that the oxygen level is low? And it turns out there's something called hypoxia-inducible factor, which is released constitutively. That means it's made all the time, everywhere. but it gets deactivated if there's normal oxygen in tissue. And if the oxygen level is low persistently, this hypoxia-inducible factor will increase. And one of the things that it can do is cause bone resorption or osteoporosis. And I think that that's the mechanism for the osteolysis, the bone resorption shown on those slides, and the shortening of the digits. And we also know that hypoxia can be a trigger to fibroblast, that it is one, as I mentioned in the GI tract, I think it has a reparative role or a preventive role to prevent you from getting bowel perforation, that fibrosis, not being the driver of the process, but actually something that follows the microvascular disease. So this I largely already discussed, that there's a loss of capillaries, there's less blood flow, there's tissue hypoxia, there's loss of nutrients, there is loss of tissue, but there's also induction of fibrosis by the low oxygen level in the tissue. And apoptosis is, I believe, the process that's going on in a lot of places with scleroderma, and again, that means programmed cell death. So we think of so not gangrene, not an ulcer, but the tissue gets thinner because it's less perfused. So, so in summary, I think that vascular disease is even more important than fibrosis. Fibrosis is kind of the textbook photo of someone with scleroderma, but that the vascular disease precedes it. It's present in everyone with scleroderma to greater or lesser degree. There's a reduction in the density of capillaries. They take on chaotic shapes, and I believe it also has a role in inducing fibrosis. What causes the damage to the blood vessels? Well, first, we know there are some viruses that are what are called endotheliotropic. That means that instead of going to your skin or your heart, whatever, they go to blood vessels. And CMV and parvovirus in particular. And these are not universally identified in individuals with scleroderma, but there are plenty of individuals with scleroderma where they have been found. And they land in the endothelium, in the inner lining of the blood vessels, and they trigger an immune response. And so in addition to finding the viruses, you'll often find evidence of activation of interferon. And interferon at high levels for a prolonged period of time can further damage the blood vessel wall. And exposure of what antigens that are usually invisible can then result in what are called anti-endothelial cell antibodies, autoantibodies against the lining. So you create this stew of factors that can cause vascular damage. So you get thickening of the capillary walls, you get a narrowing and obliteration of the lumen. Nitrous oxide is present all the time, but it is reduced. It's a vasodilator. You get elevated levels of what's called endothelin, something naturally produced, which is the most potent vasoconstrictor. And in scleroderma, you get, I believe, absent or deficient angiogenesis. That means you lose blood vessels. That would be okay if you could replace them just as rapidly, but you can't. And I believe it's due to deficient endothelial progenitor cells. These are like stem cells for blood vessels. But you get these funny blood vessels, these enlarged blood vessels, because the body tries to deal with this as best it can. There's an elevated level of what's called vascular endothelial growth factor.
Can you stop that or slow that with anti-VEGFs like we do with macular degeneration? Is there anything to talk about that?
So you probably could, but I don't think, except in those people who may be, actually there is a disease called hereditary hemorrhagic telangiectasia, where they get telangiectasia all over the place, dilated blood vessels. And yes, that is an approach that's used in that disease because they get problems with bleeding to a much greater degree than individuals with scleroderma. So I suppose in someone with scleroderma where that was the predominant problem, where they had intractable GI bleeding, you might take that approach, but it hasn't been used. So you could stop the telangiectasia from forming, but that wouldn't address the problem of you're just not forming new blood vessels. So it's extremely hot and humid. And I guess you really didn't need a weather forecast, but I'm going to, it's cloudy. Yeah. Yes, it's cloudy also. So I wanted to end with just talking about a miracle, and I wish in talking about this I had gone maybe to divinity school so I could speak with that degree of animation. Animation comes as slowly to me as blood flow in those individuals with bad Raynaud's. So I want to talk about Dagoes disease, which maybe I heard of it, but I had never seen it. And but encountering it, I believe, was a miracle, and that it has and will have relevance to the treatment of scleroderma. So Dagoes disease was one of those diseases named after a French dermatologist, and it's being replaced as a name as malignant atrophic papulosis. Now, I kind of like the name Dagoes disease better, but anyway, so in this disease, people get these little areas that the outside might look like a telangiectasia, but the inside there's absolutely no blood vessel you can see, even with a hand lens. And there's this little area of thinning, but also some fibrotic changes. And if you do a biopsy, there's some similarities to scleroderma. There's loss of blood vessels, and the blood vessels that are there have a thickened wall. And in that little patch, so it's not all over the place, it's these little patches, those changes exist. Well, in this disease, most people present with the skin lesions, but 1 out of 3 will go on to develop similar changes in the GI tract and or in the brain, and it's called malignant atrophic papulosis because if you're in that 1/3, and it can take a few years to evolve from this to that, and so this is the same person, and the skin lesions are still there, but they're also there on the bowel. They do perforate, and unlike people with scleroderma who don't, and they die of that, or they die of strokes. So I did encounter a 17-year-old high school student who had these skin lesions for a couple of years, and when you have an ultra-rare disease, he saw 3 dermatologists before they said it was Dagoes disease. And you go on the internet, and they got very upset because they saw it's bad. And then he was very stoical, but 2 years later he started getting belly pain, which culminated in bowel perforation, and then it kind of happens like Roman candles. There are lots of these lesions, you can't see them all. So if you have bowel perforation, it means you're at risk for more bowel perforation. And so he had a second bowel perforation, and they couldn't, the bowel was swollen. They couldn't put it all back in, and so he was lying in the ICU with the bowel out like that. And it's an ultra-rare disease, and there was no treatment in the literature. And I consulted the experts on the disease, and there was no treatment. So then a series of miracles started to happen. And I got out of bed one morning. I thought, if I don't come up with an answer today, he will die, which actually, that wasn't true, but it was motivating. And so an email came that day about a pulmonary hypertension study, and there were a lot of scleroderma researchers, and it was an unblinded email, so I could write these people, and I said, I have this 17-year-old with this disease. I didn't know if any of them knew anything about Dagoes disease, but I knew nobody else did, so do any of you have an idea? And we're linked enough. Out of those 30, 12 answered within 2 hours, and 9 said, good luck. 2 said they'd seen someone like that and the patient had died. And the 12th wrote me from Portugal. She was at a meeting. Actually, she was having lunch with Dr. Steen, who, my mentor. She was having lunch with Dr. Steen at a meeting in Portugal and said, funny you should write. We had a very similar patient at Cornell 3 weeks ago, tried a new medicine, fantastic results. And it wasn't her patient. She just knew about it. So she had to write to New York, get the name, went back to Portugal, back to me. And I had never heard of the drug, just like I'd never heard of the disease. But we got I called up the medical director of the company, said I had this 17-year-old who was dying. I know you used the same medicine 3 weeks before. Could we get it? And she said yes. And we got it 3 days later, delayed by a snowstorm. And his father texted me an hour later and said, it's working, 10 exclamation points. And basically all the inflammation went away, but what happened right away was his blood pressure normalized, his fever disappeared, they were able to close up his belly, and he gave an Easter sermon at his church a couple months later. And well, so that wouldn't sound like it was immediately relevant to scleroderma, except the answer came from the scleroderma world community. But then a year later on this treatment, which was really to suppress inflammation in the blood vessels, it wasn't a treatment that's applicable to scleroderma, his disease progressed. So even though he stayed on the medicine, he started having multiple strokes. He was 18. And he developed hematuria, bleeding from his bladder. He had similar lesions to those on the gut in his bladder. And then again, I thought he was going to die. And I knew, I'd already examined the whole world for experts, and they found this one treatment, and I couldn't send them same people an email that I knew there was nothing else. Then somebody walked in, and she gave me the answer. And she did have scleroderma. And this is why I think one disease might inform another. So she had scleroderma, she had pulmonary hypertension. She was short of breath walking across a couple rooms in her house. And she had these skin lesions that didn't look like classic telangiectasia, but looked an awful lot like the skin lesions of the boy I just showed you. And on biopsy, they were indeed Dagoes disease. So she had scleroderma and Dagoes disease. So she went on treprostinil, which is a drug we do use for scleroderma. And she came back 3 months later, and she said, my breathing is much better. I can walk a golf course. She was a responder. And my skin lesions are better, too. And what happened was, basically, they disappeared over time. They were very extensive. And, but then those all have disappeared. And that was 6 years ago. And so she's still on this medicine. It's worked for her pulmonary hypertension. It's worked for her skin. But we were able to get the medicine for the boy who was having the strokes and the bladder lesions, and he got all better. And and he's working in my office now, and he's going to go to a PA school. And it turned out we've used it in 3 other people, this combination, and it's worked. So treprostinil is a drug that's used for pulmonary hypertension, and it's known to relax blood vessels, but it wouldn't make improvement where there are no blood vessels, which I mentioned that there's this problem in scleroderma with angiogenesis making new blood vessels, so that we hit a wall with some treatments. Some people will respond very well to Cialis, others won't. You can dilate blood vessels, but if there aren't enough blood vessels, you'll get a limited response, and that's true whether it's Raynaud's or pulmonary hypertension. So I thought, how does this work? And so I did what you do, I just did a little search, and it turned out there's a doctor in Paris who was looking at treprostinil in people with pulmonary hypertension, and I don't know why he looked, but he found that it did increase endothelial progenitor cells, the cells that you need to make new blood vessels. And then I observed people on this drug who had calcinosis. They had pulmonary hypertension and they had calcinosis. And they reported that their calcinosis had decreased. So I discussed this with my colleagues, and actually they're now doing a study of treprostinil for calcinosis at Stanford University. Again, with not because it dilates blood vessels, but although it does do that, but that it may also increase blood flow by creating new blood vessels. And maybe that's the answer to ultimately to stopping that bone loss and stopping the calcinosis. So the other thing, and I want to go back, in terms of the vascular theory of the GI tract, is we can do as many barium swallows or barium enemas or endoscopies or colonoscopies as we want, but we're only looking at one side of the bowel. And now in watermelon stomach, we can see those blood vessel changes on the inside. But I think if we looked somehow more often at the outside of the bowel in individuals with scleroderma, we would discover that the blood vessel changes are happening there, and that it may simply be that this loss of blood vessels results in poor oxygen flow and thinning of the blood vessel. It may be that the poor blood vessel flow damages the nerves that supply the gut, And so if you denervate the bowel, if the nerves die, it's not going to work very well either. But in either case, I believe that it's the blood flow that is the biggest issue. And so in this disease, he in fact had a colonoscopy, and there have been a bunch of people who had colonoscopies that were normal in this Dagoes disease, and then they had a bowel perforation not very long afterwards. And so on the colonoscopy, the changes were very, very subtle. But on the surgery, they were very, very obvious. And so that made me think that in scleroderma, maybe we would know a lot more. This was surgery, and this was surgery because of an abdominal catastrophe, so you can't do that routinely. But that if we find ways, and we maybe, the mouth will be a way we can do it, if we can look for blood vessel change. If we have ways of measuring blood flow early in the disease, we may be able to come up with a new mechanism, or at least support the mechanism that poor blood flow is the basis of the thinning, and that this is another target for therapy. So again, I just want to close by again emphasizing the universality of this blood vessel disease. It varies in severity, individual to individual, in one individual over time, in one individual in terms of one organ to another one. And I want to thank the Scleroderma Foundation Tri-State for their support, Albany College of Pharmacy, specifically Jessica Farrell, my pharmacy sidekick, who's been so helpful, and the staff of the Stephan Scleroderma Center, my research coordinators, and Jessica should get thanks twice, and my secretary and librarian who have helped with the research. And gosh, I feel like jumping in right now, so thank you very much.